In the next section, we will examine how the APPHC partnership learned from providers' experiences to improve service quality and postpartum hemorrhage outcomes, and to advance respectful maternity care more generally. A key finding from this study is how a provider's mental health and well-being can influence the quality of care that they deliver. It's essential that we better understand how these factors interact in order to effect sustainable changes in behavior. To examine providers' experiences, we first identified relevant measures of work-related stress and mental health challenges frequently encountered by healthcare providers. Based on initial scoping meetings and a collaboration with national partners and stakeholders, we identified burnout, a psychological syndrome characterized by chronic exhaustion, detachment, and limited professional growth, as a primary concern among experts and maternity care providers in Malawi and Madagascar as contributing to poor quality of care. We use the Maslach Burnout Inventory as an appropriate measure of burnout for two reasons. First, it describes burnout across three dimensions: emotional exhaustion, depersonalization, and professional accomplishment. Second, the measure has been previously used and validated in low and middle income country contexts, including in Malawi. After our initial examination of the baseline data, we determined that a broader picture of providers' mental health was necessary. Therefore, we were able to capture data on providers' experiences with depression and post-traumatic stress disorder using the 9-item PHQ-9 depression screening tool and the 5-item primary care PTSD screening tool. This was done in Malawi only. We found that many providers experience different aspects of burnout in both countries. The solid boxes in the chart below show the baseline data for emotional exhaustion and depersonalization. Blue represents Malawi, green Madagascar. The shaded area on top represents the changes observed at endline. So for instance, in Malawi, the initial measurement showed an average of 28.1, which by endline had increased to 31.6. While levels of depersonalization were consistent across both countries at baseline, emotional exhaustion was significantly higher in Madagascar than in Malawi at both time points. But in Malawi, we see a more marked increase in both emotional exhaustion and depersonalization between baseline and endline compared to Madagascar. This may be related to social distancing measures implemented in facilities during the COVID-19 pandemic. The findings from this study are comparable to others conducted in Malawi on burnout. In this instance, 40% of Malawian providers experienced significant emotional exhaustion, and 30% experienced significant depersonalization. To examine how providers experience symptoms of burnout, we grouped their responses from all providers interviewed at baseline and endline in Madagascar and in Malawi and found consistent trends between the two countries. Nearly half said that they felt they were working too hard 2 or more times per week. Roughly a quarter reported feeling emotionally drained, out of patience, or burned out from their work, or that they felt tired when they thought about going to work at least twice per week. A provider from Madagascar expressed the following: "Sometimes there are moments of great weariness. You don't feel good. We work 7 days a week, but most of all you work all day, and at night too there are more patients, sometimes women in labor. At times you feel mental fatigue, like you're affected, stressed, unmotivated." The behavior change activities conducted through the APPHC partnership led to new recognition among providers that they were not alone in experiencing burnout, and that burnout can impair their ability to provide effective care. In Malawi, we also found that 7.5% of all providers reported current symptoms consistent with moderate to severe depression, or depression that should require a treatment plan and medication. Depression rates were twice as high in PHCs. In total, over half of providers reported any depressive symptoms, and 60% of those reported that the issues they experienced made their work more difficult. Nearly 70% of providers reported experiencing a traumatic event that could lead to PTSD. Among these, around 17% subsequently screened positive for PTSD, representing just over a tenth of the endline sample. Nearly a quarter of physicians or clinical officers screened positive for PTSD, and the condition was most common in community hospitals. 8.5% had considered harming themselves or thought that they would be better off dead at least once within the past 2 weeks. As with depression, the frequency of suicidal ideation was twice as high among clinicians at the PHC level.
In this slide, we're going to take a look at how the different aspects of providers' mental health affect the ultimate outcome of respectful maternity care. What we first see is that both depression and emotional exhaustion have direct effects on respectful maternity care. That is to say that as depression scores increase or emotional exhaustion increases, respectful care goes down. We next look at the mediated effects of depersonalization and post-traumatic stress disorder. Depersonalization has a strong direct effect on depression, meaning that as depersonalization increases, depression also increases, conferring a decrease in respectful maternity care. PTSD, on the other hand, has broad-ranging effects on depersonalization, depression, and emotional exhaustion, meaning that PTSD has a broader impact on the provider's mental health and well-being. Is that that relationships with health facility management can have a powerful protective effect against both depersonalization and emotional exhaustion, mitigating these two aspects of burnout, while also directly improving respectful maternity care. This pathway analysis highlights different opportunities for intervention, both in dealing with providers' mental health vis-a-vis PTSD and depression, but also showing how relationships with facility management can mitigate burnout.
As depression and/or emotional exhaustion increase, RMC scores go down. We also examine mediating effects. These are factors that do as important as understanding mental health and well-being appear to be. Provider vulnerabilities and challenges often change from site to site. Therefore, future activities should engage providers directly, empowering them to identify not only their highest priority challenges, but also to find local solutions to these site-specific problems. Many providers work in challenging situations with limited equipment, supplies, and support. Overcoming these challenges remains their foremost concern, but can be mentally taxing and can affect their clinical decision-making. Providers' vulnerabilities are often context-dependent, and centralized solutions do not always capture the differences between facilities. For example, while relevant policies and guidelines are critical, programmers must understand the specific needs and priorities of providers themselves to identify potential barriers that may affect how such guidelines are implemented. Poor performance on PPH prevention and care may appear to be the result of inadequate training or knowledge, but providers in one facility may indicate a lack of training opportunities as a key problem, while staff elsewhere might describe critical workforce shortages, and others still may suggest poor relationships with facility management contribute to a blame-focused culture and fear to act. We used a pragmatic approach in both countries. In Madagascar, breakthrough research partner Ideas 42 collaborated
with healthcare providers.
PPH prevention tasks, such as a minute timer to remind them to administer oxytocin after delivery, or to assign some of the non-clinical support roles to family members who are attending a delivery. Then, in an iterative process, Ideas 42 worked with the providers to refine these solutions and assess their usability and appropriateness to the context. In Malawi, the APPHC partnership worked closely with the Ministry of Health and the ONSE project to enhance their existing mentorship and teamwork model. The APPHC partnership provided mentors with tools to assist providers with identifying and addressing site-specific barriers to managing PPH and obstetric complications. These tools included an adaptation of the Values Clarification and Attitude Transformation, or VCAT, toolkit, and the Caring for Carers strategy to help providers reflect on their work, manage stress, and feel respected in their roles to reduce burnout, improve motivation, and support providers to manage PPH. In both countries, self-efficacy to manage PPH increased between baseline and endline in areas where providers were included in identifying and addressing their problems compared to comparison sites. These findings suggest that even across different countries and contexts, understanding providers and actually using their input may improve self-efficacy to provide care and increase sustainability in the long term. Chronic HR shortages lead to small numbers of staff who work long hours and have their attention stretched across many patients and responsibilities. However, birth companions are recognized by the WHO as supporting improved care and delivery experiences for women and have been incorporated into the National Labor and Delivery Guidelines in both Madagascar and Malawi. Birth companions represent a critical resource to whom simple, non-medical tasks such as fetching water or supplies or alerting a provider to excessive bleeding can be shifted. Yet many providers perceive birth companions as unnecessary. With space in wards at a premium, providers we interviewed often said they did not permit companions in order to protect women's privacy or prevent overcrowding, especially during the pandemic. However, further investigation suggested that some companions who were not actively engaged with their person clustered around women in active labor and could sometimes undermine the instructions of attending facility staff. Thus, many women were not permitted a birth companion to accompany them throughout labor and delivery. However, we found that defining the supportive roles that birth companions can assume for both the providers and communicating these roles to the companion themselves is key to changing their perceived value and expanding their presence. In Madagascar, women are often accompanied to labor units by multiple family members. In this context, task badges were used to assign specific roles to each family member. One would come for the patient, another would monitor for bleeding or other emergencies and alert the facility staff. A third member might run for supplies or fetch water. By assigning a specific role to each person, the family members were engaged in the process, and providers could more easily communicate with each person to accomplish specific tasks. During interviews, providers expressed that being able to delegate concrete, non-clinical tasks simplified their work. One said, "The badges are fairly new, so we're just getting used to it. The good thing is that we don't ask the family to do this or that. Each one has his own task. This makes our work in the delivery room much easier." In Malawi, national guidelines on best practices indicate that a woman should be accompanied during labor and delivery by a birth companion of her choice. In fact, the Reproductive Health Directorate ensured that birth companions were included in the Malawian COVID response guidelines, which provided for one birth companion per woman in labor. However, pre-pandemic baseline data indicated that providers did not always allow a companion to be present. To support national guidelines, we work closely with maternity providers and the Reproductive Health Directorate to develop briefing materials comprising an information pamphlet to assist providers in briefing birth companions on their roles and responsibilities, and a poster that included images designed by local partners, along with text that served as a reminder to companions about their tasks. The materials were tested in 11 facilities. Monitoring data indicates that 3/4 of providers had seen the posters and 2/3 had used the materials to brief companions during the trial period. One provider said that these materials were straightforward, very readable, and that it's easy to understand and tell others what they're saying, so they're very helpful. Assigning tasks to companions appears effective in increasing their attendance. Data from clients interviewed in intervention sites in both countries showed that a significantly greater proportion reported that their birth companion was allowed to support them throughout labor and delivery. In Madagascar, the proportion of women in intervention sites who had a family member in attendance increased from 73% to 88%. In Malawi, companion admission increased from 30 to 51% in intervention groups. We observed decreases between baseline and endline in comparison facilities in both countries, and hypothesized that COVID-related fears and social distancing measures may have influenced broader trends in companion attendance. Ultimately, when birth companions were present, clients in both Malawi and Madagascar reported receiving RMC. In intervention sites where companion admission increased significantly between baseline and endline, so did client-reported RMC scores. However, one of the most important findings here was that providers perceived the value of the birth companions in monitoring clients for PPH. One nurse midwife in Malawi said, "I was on night duty. After orienting them, I was checking on a baby and the mother. So one of the birth companions I briefed came to me and said, 'You just told us to be observing our clients for bleeding. Look, this woman is bleeding.' This final slide summarizes our work in both understanding the influence of providers' mental health and well-being and in developing context-specific interventions to overcome these challenges. We have documented that depression and emotional exhaustion influence RMC directly, and that depersonalization has a strong positive correlation with depression. But we have also seen that strong, supportive relationships with facility management can mitigate the effects of burnout, and that where providers are involved in identifying and solving their own challenges, their self-efficacy improves. We've also demonstrated that a pragmatic approach to including birth companions as part of the birthing partnership, woman, companion, or family member and provider, can improve the care received as well as reduce stress on the provider.